Welcome to the MRCPology channel for a quick review, understanding, and revision of the topic. Imagine a patient suddenly develops the worst headache of their life during exercise or sexual activity. The pain is immediately severe, perhaps with vomiting, collapse, neck stiffness, or a focal neurological deficit. The first priority is not simply to control the pain. The priority is to identify a potentially fatal intracranial vascular event. A thunderclap headache is a sudden, severe headache that reaches maximal intensity within seconds and, by definition, within less than 1 minute. The key clinical principle is that a first presentation of thunderclap headache must be treated as subarachnoid hemorrhage until proven otherwise. To understand thunderclap headache, think in 4 boxes: the underlying mechanism, the important causes, the clinical warning signs, and the urgent diagnostic approach. First, consider the mechanism. An abrupt intracranial vascular event causes sudden stretching or irritation of pain-sensitive structures, particularly the meninges and intracranial blood vessels. Alternatively, there may be a rapid change in intracranial pressure. This sudden meningeal irritation or pressure change produces the explosive, maximal at onset pain that characterizes a thunderclap headache. The most important cause is aneurysmal subarachnoid hemorrhage. Rupture of an intracranial aneurysm releases arterial blood into the subarachnoid space. The blood irritates the meninges and may rapidly increase intracranial pressure. This explains the sudden severe headache, vomiting, meningism, reduced consciousness, and sometimes collapse or syncope. The key clue is a headache that is maximal immediately, particularly when accompanied by neck stiffness, vomiting, altered consciousness, or neurological signs. A patient may describe it as being hit on the back of the head or as the worst headache they have ever experienced. Another important cause is reversible cerebral vasoconstriction syndrome, commonly abbreviated to RCVS. Here, transient multifocal narrowing of the cerebral arteries produces recurrent thunderclap headaches. Unlike aneurysmal subarachnoid hemorrhage, which often causes a single catastrophic headache, RCVS commonly produces several thunderclap headaches over days or weeks. RCVS may be triggered by physical exertion, sexual activity, the postpartum state, or exposure to vasoactive substances, including serotonergic and sympathomimetic drugs. The cerebral arterial abnormalities are usually reversible, but complications such as ischemic stroke, intracerebral hemorrhage, convexity subarachnoid hemorrhage, or posterior reversible encephalopathy syndrome may occur. MRCP trap, recurrent thunderclap headaches, do not make the condition benign. Recurrent episodes should raise strong suspicion of RCVS, especially when there is a recognized trigger. Cervical artery dissection is another vascular emergency. An intimal tear allows blood to enter the arterial wall, creating a mural hematoma. This can cause sudden head or neck pain and may narrow the vessel or generate thrombus, resulting in cerebral embolism and ischemic stroke. Carotid artery dissection may cause unilateral head, facial, or neck pain with a partial Horner syndrome. Vertebral artery dissection more commonly causes posterior neck or occipital pain and may be followed by posterior circulation neurological features. The neurological deficit may appear after the pain than at the same time. Cerebral venous sinus thrombosis should also be considered. Thrombosis obstructs cerebral venous drainage, causing increased venous pressure and raised intracranial pressure. The patient may develop severe headache, papilloedema, seizures, focal neurological deficits, or reduced consciousness. Pregnancy and the postpartum period are particularly important risk settings. Other associations include estrogen exposure, malignancy, systemic inflammation, infection, and thrombophilia. The headache is not always thunderclap in onset, but cerebral venous sinus thrombosis must remain in the differential, especially when headache is accompanied by seizures or signs of raised intracranial pressure. Pituitary apoplexy occurs when hemorrhage or infarction develops within a pituitary adenoma. The rapid expansion produces sudden severe headache, visual impairment, visual field defects, and ocular motor abnormalities due to involvement of structures around the cavernous sinus. The key clue is thunderclap headache with visual symptoms or ophthalmoplegia. Acute adrenal insufficiency may also occur because of impaired adrenocorticotropic hormone secretion. This can cause hypotension, hyponatremia, and circulatory collapse, making urgent glucocorticoid treatment potentially life-saving. Other serious causes include intracerebral hemorrhage, meningitis, posterior reversible encephalopathy syndrome, and spontaneous intracranial hypotension. Spontaneous intracranial hypotension classically produces a postural headache that becomes worse when upright and improves when lying flat, although the onset can occasionally be sudden. Now consider the clinical red flags. Collapse or syncope may indicate an abrupt rise in intracranial pressure or a major hemorrhage. Vomiting and reduced consciousness suggests significant intracranial pathology. Meningism suggests irritation of the meninges by blood or infection. Seizures, focal neurological deficits, and papilloedema raise concern for hemorrhage, venous thrombosis, arterial dissection, RCVS, or another structural cerebral lesion. Neck pain should raise suspicion of cervical artery dissection, although it can also occur with subarachnoid hemorrhage. Pregnancy or recent delivery should increase concern for cerebral venous sinus thrombosis, RCVS, and hypertensive disorders, such as posterior reversible encephalopathy syndrome. Anticoagulant treatment increases the risk and potential severity of intracranial bleeding. An exertional or sexual onset is a particularly important clue. Although primary exertional and primary headache associated with sexual activity do exist, they are diagnoses of exclusion. A dangerous vascular cause must be ruled out first. The initial investigation is an immediate non-contrast CT scan of the head. This is used to identify subarachnoid blood, intracerebral hemorrhage, mass effect, or other obvious intracranial pathology. The diagnostic sensitivity of CT for subarachnoid hemorrhage is highest when it is performed early after headache onset. A negative CT scan does not automatically exclude a serious cause. The next step depends on the timing of the scan, the quality and interpretation of the imaging, the clinical level of suspicion, and the suspected diagnosis. When suspicion of subarachnoid hemorrhage remains, lumbar puncture may be required after the appropriate interval following local diagnostic guidance. Cerebrospinal fluid is assessed for evidence of bleeding, including red blood cells and xanthochromia. Before lumbar puncture, clinicians must consider contraindications such as mass effect, obstructive hydrocephalus, severe coagulopathy, or other features suggesting that the procedure may be unsafe. Further vascular imaging should be selected according to the suspected cause. CT angiography can identify an intracranial aneurysm and may demonstrate arterial narrowing or dissection. Magnetic resonance angiography is an alternative in selected situations. CT or magnetic resonance venography is required when cerebral venous sinus thrombosis is suspected. MRCP trap, a normal non-contrast CT, does not exclude RCVS, cervical artery dissection, cerebral venous sinus thrombosis, or pituitary apoplexy. The imaging strategy must follow the clinical clues rather than stopping after the first normal test. Initial management requires urgent emergency and neurological assessment. Stabilize the airway, breathing, and circulation, assess consciousness, perform a focused neurological examination, and provide appropriate analgesia and antiemetic treatment. Blood pressure should be assessed and carefully managed when intracranial hemorrhage is suspected, avoiding both severe hypertension and excessive reduction that could compromise cerebral perfusion. Early neurology or neurosurgical involvement is required when a vascular or structural cause is suspected. Definitive treatment then depends on the diagnosis. An aneurysmal subarachnoid hemorrhage may require urgent endovascular or neurosurgical intervention. Cerebral venous sinus thrombosis usually requires anticoagulation unless a specific contraindication exists. Pituitary apoplexy requires urgent endocrine and specialist assessment with immediate glucocorticoid replacement when adrenal insufficiency is suspected. Do not confuse the symptom with the diagnosis. Thunderclap headache describes the speed and severity of headache onset. It does not identify the underlying disease. If you remember one thing, remember this: never diagnose a primary thunderclap headache until dangerous secondary causes have been appropriately excluded. Quick recall: a postpartum patient has several recurrent thunderclap headaches triggered by exertion, and initial non-contrast CT imaging shows no major subarachnoid hemorrhage. Which diagnosis should be strongly suspected, and what investigation helps demonstrate the underlying abnormality? The answer is reversible cerebral vasoconstriction syndrome, and cerebral arterial imaging with CT angiography or magnetic resonance angiography may demonstrate multifocal arterial narrowing. A patient develops sudden severe headache, posterior neck pain, vertigo, and limb ataxia after minor neck movement. The initial CT head is normal. What dangerous diagnosis must not be missed? And why can neurological features occur after the pain begins? The answer is vertebral artery dissection. An intimal tear produces a mural hematoma and thrombus, which may subsequently cause arterial narrowing or embolization into the posterior circulation. Do subscribe to the channel for further videos.